Hi, my name is Eric Plakin, and I'm the Director of Admissions and Professional Relations at the Austin Riggs Center in Stockbridge, Massachusetts, and the past chair of the APA Committee on Psychotherapy by Psychiatrists. I'm here at the Institute on Psychiatric Services today talking about why psychiatrists don't do psychotherapy even though it works. This has to do with a study that came up several years ago by Mojtabai and Olfson showing that from 1996 until about 2005, there had been a significant decline in the frequency with which psychiatrists reported doing psychotherapy as part of their practices, a decline from about 44% to about 29% of their interactions with patients. This interested us in the American Psychiatric Association Committee on Psychotherapy by Psychiatrists, and working with APIRE, we put together a survey to try to understand what are the obstacles. And we found some interesting things. We found, for example, that a lot of the decline had to do with the fact that psychiatrists are not reimbursed the same for doing psychotherapy as they are for doing psychopharmacology. And that lower compensation, that lack of parity, if you will, in the kind of payment for the provision of services seemed to be an important one, as well as the administrative burden that's part of trying to do psychotherapy these days. The fact is that often there are extensive requirements to try to interface with and justify with an insurance company the need for psychotherapy. We found this to be a significant barrier. We also found that the group that was doing psychotherapy, and indeed there's a significant group of psychiatrists who are still providing psychotherapy services to many, maybe even most of their patients, that group tends to be the group that's older. It tends to be the group that's 65 and older. And we realized this was a kind of a warning sign for us in the field that there was a danger that as this group aged out and retired, that there would be a further decrease. And there's a real worry about where future psychotherapy skills are going to be found in the psychiatrist of the future. Why is this important? Well, the simple fact is that psychotherapy works. There's evidence that psychotherapy is effective for a range of individual disorders across a range of schools of therapy, and that psychotherapy is effective for complex comorbid disorders. In fact, there are some instances when psychotherapy is the preferred treatment, as in the case of patients with personality disorders. It's also the case that we have evidence that psychotherapy is a biological treatment. In fact, we can, in some studies, tell the difference between therapy responders and non-responders by imaging studies and by seeing changes in their brains. Plus, we're learning that psychosocial factors play a much more important role than we realized previously in the causation and in the treatment of mental disorders. We're learning that early adversity in life is associated with the development of a range of axis 1 and 2 disorders and with comorbidity. And we're learning that having multiple disorders like personality disorder with a major depressive disorder significantly increases the risk that a patient will fail to respond to otherwise effective treatment and become treatment resistant. We're learning also, for example, from the STAR-D study, that close to 80% of patients actually have the kind of complex comorbid disorders that make them less likely to respond to treatment. So it seems to me quite important that we be able to preserve a way to include psychotherapy as part of the skill set and identity of psychiatrists and include it in residency training, so that future generations of patients will have the opportunity to have psychotherapy provided by a psychiatrist who can do the maximum integration of bodily, medical, and psychological issues in a way that no other discipline can. And hence our session and our hope that we can move away from a kind of biological reductionism that has left our field with what Steve Sharfstein, when he was APA president, called a bio model that's replaced the biopsychosocial model to some extent. We'd like to see psychiatrists trained in, able to use, and comfortable with psychotherapy in all aspects of their practice, including thinking psychologically even when they're prescribing and not doing psychotherapy.